All right, let's jump right into a topic that is absolutely guaranteed to show up on your surgical boards: non-melanoma skin cancers. We're going to build a high-yield playbook for the three main types and really focus on those critical decision points that separate a right answer from a wrong one. Let's do this. So here's our game plan for today. We're going to start with the big picture, the cutaneous cancer triad. Then we'll build a specific surgical playbook for basal cell, then squamous cell, and finally, the most aggressive of the bunch, Merkel cell. We'll wrap it all up with a head-to-head comparison and a quick knowledge check to make sure this stuff sticks. Okay, first things first, let's set the stage. To really get a handle on these cancers, you've got to see how they relate to each other. And that's what this whole idea of the cutaneous cancer triad is all about. Now, this is a fantastic way to visualize the whole NMSC landscape. I want you to notice the inverse relationship here. At the very wide base, you've got basal cell carcinoma. It makes up a whopping 80% of cases, but its risk of spreading, it's tiny, less than 0.1%. Then you get to Merkel cell, way down at the sharp tip. It's super rare, but it is way more aggressive, with a metastasis rate around 30%. And this right here is our main theme. You have to burn this into your brain for your exams and for your practice. You cannot judge how dangerous a skin cancer is by how common it is. The most common is the least deadly. And the rarest? Well, that's the one you really have to worry about. So all three of these share the classic risk factors you'd expect, right? Sun exposure, fair skin, getting older, and being immunosuppressed. But the boards are going to test you on the unique stuff. For squamous cell, you have to remember the link to HPV and to Marjolins ulcers. Those are the ones that pop up in chronic wounds or old burns. And for Merkel cell, the big one is the Merkel cell polyomavirus, which is found in about 80% of cases. All right, quick pop quiz on that last point. You've got 5 seconds. Which one of these cancers has that strong viral connection we just talked about? You got it, it's Merkel cell carcinoma. That Merkel cell polyomavirus is a huge player in how this cancer develops. That is a super high-yield fact. Don't forget it. All right, now that we've got the lay of the land, let's dive into our first playbook. We're focusing on the most common player out there, basal cell carcinoma. So to manage BCC correctly, you absolutely have to know these risk zones, H, M, and L. The most important one to remember is area H. Think of it as the central mask area of the face, plus other really important spots like the ears, hands, and feet. And here's the key. Any BCC in area H, I don't care what size it is automatically considered high risk. For areas M and L, the cutoff for being high risk is 2 centimeters. Okay, here's a classic scenario for you. You've got a patient with a 1.5 centimeter basal cell carcinoma right on the side of their nose. Based on the rules we just covered, what's the best way to manage this? The correct answer, hands down, is Mohs micrographic surgery. And why is that? Because the nose is smack dab in the middle of area H. The size, 1.5 centimeters, is completely irrelevant here. Location is king, which makes this high risk by definition and means you want the precision of Mohs. Let's do some rapid-fire pearls and traps. First, know your subtypes. Morpheoform is the most aggressive, and it loves to come back. Basosquamous, well, it acts more like a squamous cell, so you treat it like one. If you have a patient with Gorlin syndrome, that's the genetic one that causes tons of BCCs. Radiation is a huge no-no. For meds, vismodegib and sonegib target the hedgehog pathway, but you got to warn patients about the gnarly muscle spasms. And the biggest trap of all, you never, ever, ever do a sentinel node biopsy for a pure BCC. Okay, let's level up. We're moving to the middle of our pyramid with cutaneous squamous cell carcinoma. This one has a much wider range of risk, which makes the management a little more complicated. Squamous cell usually follows a pretty predictable path. It often starts as a precancerous actinic keratosis, then it becomes Bowen's disease, which is just carcinoma in situ, and then finally it becomes invasive. Now, you also have to be on the lookout for the aggressive variants. Marjolins ulcers, which are nasty tumors that grow in chronic wounds, and the volcano-shaped keratohematoma, which you should always just treat like a well-differentiated SCC. So, figuring out the risk here is a bit more nuanced. A tumor becomes high risk if it's an area H, bigger than 2 centimeters, or between 2 and 6 millimeters deep. But it jumps up to very high risk if it's over 4 centimeters, invades into fat, or, and this is a huge distinction for the boards, if there's clinical perineural invasion, or CPNI. That means the patient is actually having symptoms, like numbness or pain, and that tells you the prognosis is much worse. Let's put these rules to the test. Your patient is a transplant recipient, so they're on immunosuppressants. They have a 3 centimeter SCC on the top of their ear, and the biopsy shows it's 7 millimeters deep. So, what are you going to do? This is a very high-risk lesion, for sure. Let's break it down. 1, the patient is immunosuppressed. 2, it's on the ear, which is area H. 3, it's 3 centimeters, which is bigger than 2. And 4, it's 7 millimeters deep, which is more than 6. All of these things together mean you have to be aggressive. Wide excision with at least a 1 centimeter margin, plus a sentinel lymph node biopsy. And now, for the apex predator of non-melanoma skin cancers, Merkel cell carcinoma. This thing is rare, but it's a highly aggressive neuroendocrine tumor that demands a very specific and rigid management plan. So, on a clinical exam, how do you even start to suspect Merkel cell? Easy. You remember the AIOU mnemonic. Is the lesion asymptomatic but expanding rapidly? Is the patient immunosuppressed, older than 50, and is it on UV-exposed skin? If your patient checks 3 or more of these boxes, your suspicion for MCC should be through the roof. Now, under the microscope, MCC is a small blue cell tumor, and its main lookalike is metastatic small cell lung cancer. The way you tell them apart is with stains. MCC is classically positive for CK20, and it often has this really cool perinuclear dot pattern, and it's negative for TTF1. Small cell lung cancer from the lung, it's the exact opposite. Just remember that flip. The management of Merkel cell follows a very strict step-by-step recipe. After you get the biopsy and you do the full body staging scans, the next step is the most critical one, and it's a classic board trap. You must do the sentinel lymph node biopsy before the wide excision. Why? Because about 30% of these patients have hidden metastases in their lymph nodes, and taking out the primary tumor first totally messes up the lymphatic drainage. After the SLNB, then you do the wide excision with 1 to 2 centimeter margins down to the fascia, and then pretty much everyone gets adjuvant radiation. Okay, we have walked through each playbook individually. Now, let's put them side by side for a final face-off to really lock in the key differences and test what you remember. This table right here, this is your master cheat sheet for the exam. Look at the differences. Sentinel lymph node biopsy, never for BCC, sometimes for very high-risk squamous cell, and always for Merkel cell. The surgical margins get wider and wider as you go from BCC to MCC. And the systemic drugs and key markers, all totally different. This is gold. All right, rapid fire time. A path report on a skin biopsy comes back, small blue cell tumor, positive for CK20, negative for TTF1. What is the absolute essential next step you have to take? That's right. The answer is to kick off the full Merkel cell carcinoma workup. Those stains are classic for MCC. So that means you're ordering full body staging scans, followed by that critical sequence, sentinel lymph node biopsy first, then the wide local excision. And that is a wrap. You have now officially mastered the non-melanoma skin cancer playbook. I really hope this helps you get ready for your exams. If you want more friendly exam stories with little surgeons like me, don't forget to like and subscribe to ABSITE Daily Dose.